There is a specific, quiet stressor keeping school administrators awake at night, and it has nothing to do with test scores or graduation rates. It's about the students walking these halls and the specialized help they aren't getting. Currently, only 48% of U.S. schools report they can effectively provide mental health services to all students who need them. Just 3 years ago, that figure sat at roughly 58%. We are losing ground. At the exact same time that clinical availability is shrinking, student reports of trauma, severe depression, and acute anxiety continue to climb. Districts are left staring into a widening vacuum. They have a growing population of students in active distress and a shrinking roster of professionals available to actually sit down and help them. The historical method of managing student mental health relies on resources that no longer exist. The system is breaking down under the weight of current demand. For decades, districts operated like isolated islands. If a student needed clinical support, the school tried to hire, manage, and fund that specific expert entirely in-house. Frontline educators are working at the edge of their capacity, trapped in a funding and staffing structure that cannot sustain itself. The first major fracture occurred when pandemic-era ESSER funds finally expired. Those dollars temporarily propped up budgets for counseling staff, and when the money vanished, the positions went with it. The second fracture was logistical. Schools faced chronic, unresolvable hiring shortages for specialized roles. There simply weren't enough certified psychologists and clinical social workers applying for the open jobs. This graph illustrates the current reality, plotting collapsing funding against a flatlining supply of staff and overlaying a sharp spike in actual student clinical need. The remaining capacity gets crushed. Schools cannot mathematically or physically survive by trying to build, staff, and fund their entire clinical infrastructure within their own walls. The districts navigating this period successfully are moving away from the isolated island model and toward a partnership model. In Georgia, a prominent example of this shift is MentalSpace School, designed to act as the clinical engine behind a school's frontline staff. This flowchart maps the mechanics. When a counselor's caseload overflows, they funnel flagged students directly to the external MentalSpace clinical team. Financially, MentalSpace bills commercial insurance directly, and for families on Medicaid, the out-of-pocket cost is $0. For the student, the logistics are seamless. They receive same-day teletherapy from a dedicated, culturally competent licensed therapist, and they never have to leave the school building to attend their session. On the administrative side, the backend adheres to HIPAA and FERPA privacy laws while preparing Georgia schools for the HB 268 deadline. By integrating this external support, schools transform an overwhelming liability into an outsourced clinical reserve that protects their frontline educators from burning out. When a district stops trying to do everything itself and upgrades to this clinical partnership model, the outcomes become highly measurable. This dashboard displays MentalSpace's results, an 89% improvement in student attendance, alongside a 92% reduction in student anxiety. Expanding it reveals the community impact. Connecting students directly to care yields an 85% family satisfaction rate. Districts can no longer sustain themselves as mental health islands. The funding isn't there to support it, and the specialized staff isn't there to fill the gaps. Integrating a smart, external clinical infrastructure directly into the existing school ecosystem is the required next step for protecting student well-being. To close the 48% gap in your own district and secure the clinical capacity your students need, visit mentalspaceschool.com.